to make. One of the things that they will do if they will do a medically induced coma is they will basically decrease the sedation, decrease the effects of the medication, so that they can bring these, what we call is, make them light or bring them up, so that they can see what their level of consciousness is like, okay? So that you can truly do a good neuroassessment at that point in time. Now, one of the points that I would tell you is that when you make them light or bring them up, if the family is there, they need to visit during that time so that they can truly see. Because if I've got this person paralyzed, sedated, and on pain medication, there's going to be no response at all. But if I have weaned them off of those medications to bring them up for 15 to 30 minutes to assess their neurostatus, then they can respond to their family member if they're going to. So that is a great time for them to be able to visit. Okay? Now, other nursing interventions. I will tell you, this is probably one of the most devastating injuries that can occur to someone. You think about it, your neurological function, your brain is what makes you, you. It's your personality. It's your being. And what will happen, especially with your patients after stroke and after traumatic brain injury, is they'll never be the same. Never. They will be different in some small ways, but they will be different. They may have learning disabilities. They may have problems with speaking. They may have problems with mobility. Or they may see a personality change. But it is very psychologically devastating to family members after these types of injuries. Nutrition. We definitely want to institute nutrition on these folks. Typically what you will see is I'm not going to feed them by now, but I don't want them to go more than 2 or 3 days without some type of nutrition, whether it be enteral tube feedings, like with the Dukov, or small bore feeding tube. Typically, we don't do TPN because of the increased risk of infection. But usually that small bore feeding tube is what we do to get them nutritionally stable. You cannot heal if you don't have the building blocks to heal. And I'm going to tell you guys, with a lot of these patients, if they don't get that nutritional support that they need, then you are looking at multi-system organ dysfunction. Okay. Sensory stimulation and behavior management. Very important. You want the right amount of stimulation, but you don't want too much. Safety is going to be a big issue, especially after that immediate injury. I'm going to be concerned with their safety if I've got that intraventricular drain in. But I'm definitely going to be concerned after that thing is out and they're more awake. Because one of the first things that you often see go with any type of head injury, whether it be due to stroke, traumatic brain injury, or whatever, is judgment. They will get up and fall in a heartbeat. judgment is going to be a problem. Infection. Definitely I'm going to do meticulous care of those dressings, that interventricular catheter. But I'm also going to watch out for those lungs, because I don't want this person developing pneumonia, because coughing is going to do what to my increased intracranial pressure? Increase it even more. I don't want them to develop a urinary tract infection. Even though I may have to have that Foley in to do eyes and nose, I'm going to do meticulous Foley care, because urinary tract infections can seed and can raise and cause sepsis, especially in your elderly population. Family support is paramount. And I'm going to tell you, it can be extremely draining. Involve the chaplain, involve the social worker, involve everybody that you need to. And make sure that family has the support that they need. Now, this is just some physiologic differences between children and adults. And I'll let you take a look at those. Because what you will see is sometimes the mechanism of injury is a little different. So this is just the lecture that we've seen. This is everything you need to know about ICP. And if you can understand this slide, then you got it done. I'll talk to you later about that. So let's just look over that. All right, herniation. This is the result of increased intracranial pressure that's not able to be controlled. Because if you have that brain in a closed box and swelling occurs, the bony structures of the skull, they don't burst. When you have a headache, it may feel like it's going to, but I tell you, it won't. What happens is that brain will go down through the foramen magnum and herniate down towards the spinal cord. So herniation is a bad thing. Herniation is a bad thing. Herniation is a bad thing. Because what this means is that ICP is not controlled, and you have a patient that's at risk for imminent death. Probably, if you start seeing signs of herniation, you've got less than 30 minutes. What you see is drastic deterioration patterns. This is where that they may be alert and talking to you, and now they're not talking to you at all, or they're starting to posture. Okay? You will see Cushing's triad. Unequal pupils. And often what you will see is, remember, cranial nerves are same side. Okay? Where the left side of the brain controls the right side of the body, cranial nerves are same side. So if I've got a right-sided blown pupil, that means that is the side that's herniated. Okay? Basically, this is where you might see them do that emergency craniotomy. You might see them put in that emergency interventricular catheter. So this is what we call the normal position. Okay? You see this little thing right here, the corpus callosum? What you often see is this is called cingulate herniation, when this part of the brain sort of pushes over under that corpus callosum. Uncal herniation or temporal herniation, okay, see where this meninges right here? Part of that temporal lobe goes underneath that and it compresses on that brainstem. But the worst of the three is what we call central herniation, where the brainstem itself pushes down through that brain magnet. Don't worry about the three types. Just remember, herniation is a bad thing. Okay? Because basically, this is what we get. We get patients that are circling the drain. What they get is increased ICP, decreased perfusion, hypoxia, decreased pH, increased CO2, cerebral vasodilation, edema, which is going to cause increased intracranial pressure. It gets to be a very vicious cycle. And so what happens is that as that brain continues to swell, it goes the only place it can, that downward displacement. Now, brain death. Brain death is something that's confirmed by neurologic criteria. Basically, the first diagnosis of brain death was done, I would just say, in 1968. And in 1981, they revised some of the criteria. What you will see is an irreversible cessation of all brain functions. There are 4 prerequisites. You have coma of known cause. They come in off the street comatose and you don't know what caused it, then you have to figure out what the cause was. Okay? Normal or near normal core body temperature.
You're not dead. You're living.
There is this lovely sentence I love in the ACLS manual when it's talking about hypothermia. And it basically says you're not dead until you're warm and dead. Okay? Because basically, if you've got someone that's hypothermic, it just may be that their metabolic rate is too low for you to detect that blood pressure or pulse or respirations. Okay? Sort of like with that mammalian diving reflex we were talking about yesterday. But typically what you will see is that that is one of the criteria. They have to be normal or nearly normal core body temperature, a normal systolic blood pressure, and they've had one neurologic exam. That the neurosurgeon or the neurologist says there's no brain function. Now, used to be that we used to have to do EEGs 24 hours apart, but that's not the case anymore. In 1981, they changed the criteria to be irreversible cessation of circulatory or respiratory function or cessation of the entire brain, including the brainstem. 36 states in the United States have adopted the Uniform Determination of Death Act, and other states have enacted similar legislation. Basically, one of the things, instead of doing the EEGs now, what they will do is cerebral blood flow studies. And if there is no blood flow to the brain because of increased intracranial pressure, that is one of the criteria that they will use for determination of brain death. Okay? Typically what you will see is that these people will be comatose. They will have absence of brainstem reflexes. Their pupils do not respond to light. They will be fixed, dilated, and about an 8 or larger. Okay? You will see no ocular movement. Their eyes don't move at all. they will not have a corneal reflex. Okay, and how do I test corneal reflex?
Cotton swab to the side of the eye.
Yeah, that's the way the book tells you to do it. But I'm going to tell you, if I'm doing neuro tests on someone and I'm hooking a cotton swab in their eye every 15 minutes, what's that going to do to their eye?
Dry it out.
Or they're going to get some kind of leading little swabs in there and they're going to get corneal abrasion and ulceration. You can do it also with eye drops. Okay? Remember, corneal reflex is composed of two cranial nerves, cranial nerve 5 and number 7. Basically, cranial nerve number 5 is the sensation. Number 7 causes the blink. But there's absence of corneal reflex. There is no pharyngeal or tracheal reflex. In other words, there's no cough or no swallow. Now, along with this corneal reflex, the other thing that we look at with these ocular movements is something that they call doll's eyes phenomena or ice water calorics. They're two different tests. Doll's eyes. Okay, if you have a patient that does not have a spinal cord injury, then if you take the head and flip it very quickly, what will happen is the eyes lag and then catch up with the head. Now, if you have, and that's called positive doll's eyes. Doll's eyes negative means that when you turn the head, the eyes stay in place. The way I remember it is a good doll is an expensive doll. Think about all those little chatty Cathy's and all those dolls that you have that whenever you move their head, their eyes would open and move, as opposed to Barbie, whose eyes are drawn on, okay, or cheap dolls that have drawn on eyes, so they're going to stay fixed in place. So it's good to have eye movement. That means there's not brain death. But if those eyes stay fixed in place when you turn that head quickly, that's doll's eyes negative, and that's very poor prognostic sign. Now, ice water calorics, ice water, like drinking a glass of ice water, calorics, C-A-L-O-R-I-C-S. What we do is take a syringe full of ice water, squirt it in an intact ear, and what you should see if you've got an intact brainstem is nystagmus. Now, if you do it in an alert person, you're going to get thrown up on it. So stand to the side. But if you have a person that's brain dead without brainstem activity, when you squirt that water in, there's no movement of the eyes. Okay? So no movement of the eyes on both of those tests is a very poor sign. It means brain death is probably present. Now, apnea testing. The way they check that is often remove them from the ventilator. What we have to do is have an ABG that's somewhat normal. If they're at this point, they're going to be on a ventilator because they cannot support their respirations. A lot of times they will be on vasopressors to support blood pressure too. But what you're going to do is have them get an ABG that looks sort of normal. Then respiratory therapy takes them off the ventilator for 15 to 20 seconds to see if they're going to breathe. And you leave them off until their CO2 level rises to around 50 or so, where they should have a respiratory drive, okay, to breathe. If they don't take a breath, that's also a diagnostic sign for brain death. Okay? They do not breathe on their own. And then lastly, like I said, cerebral blood flow. They look to see if there's any cerebral blood flow in the carotids, and then go to the temporal to see if there's any up there. This is done by ultrasound and bedside. Now, one of the things you need to recognize is that a lot of these patients, excuse me, a lot of these patients that qualify as being brain dead are my young, healthy, accident victims that have traumatic brain injury. These are people that are ideal candidates for organ donation. Families should be approached, and basically what they should be approached by is the organ donation team, just not random, oh, I'm sorry your son is dead, can we have his organs? You don't do it that way. But it is somewhat time sensitive, because as the nurse, after this diagnosis of brain death, I will continue to support and maintain that blood pressure and respiratory rate until they take them to the OR for the harvest. Okay? Basically, the time of death on their death certificate will be the time that brain death is declared, not when they're removed from the ventilator to the OR. Because legally, you can't take organs from a live person. Okay? So, time of death will be declared at the time of declaration of brain death. Sometimes it may take 24 hours to get those things in place for that organ to harvest. Now, lastly, this is where it gets to be very sticky. Sticky, sticky, sticky. Now, if the person that's declared brain dead is pregnant, what you're going to see is that some states, they have all different laws. All right? Basically 5 categories. Some state laws automatically invalidate advance directives when the person is pregnant. I don't care what kind of documents you've got. If you're pregnant, they no longer apply. Some laws requires that life-sustaining treatment is provided if it is probable that the fetus will reach a live birth. Okay? Usually what you will see, what's the age of viability now?
24 weeks.
About 21 to 24 weeks. Depends on the state. Okay? Some laws consider fetal viability in determining that advanced directives. Some states allow specific treatments, but not others. And then some states are silent on the impact of pregnancy on advanced directives. We don't know. So we're not going to say anything. One of the things that you'll see is this gets very, very sticky. There was recently a case, I would say within the last year and a half in Texas. The woman was 8 weeks pregnant. 8 weeks. And brain dead. Her family elected to have her taken off the ventilator, and the hospital blocked it because of the pregnancy. They had to take the hospital to court to have this woman taken off the ventilator because she was pregnant. Texas obviously is not one of these that said that the fetus has to be of a viable age. Because at 8 weeks, most people don't even know they're pregnant.
Do you know where North Carolina stands?
North Carolina stands here. So they do look at fetal viability whenever they're she did well. She was kept on the ventilator, brain dead, for 3 months while they got an emergency injection to have a well, if you continue to feed, you continue to support, that baby's going to grow. Now, it may not be a normal development, okay? Because if you think about it, to keep this woman alive, because of the brain death, they had to keep her on major vasopressors to maintain her blood pressure. They had to occasionally defibrillate to restart her heart. I mean, the chance of normal growth at that age, first trimester, is nil.
I'm just wondering, like, the hospital in St. Louis, like, things growth, but it was going to be.
Well, see, what happened is that Texas is one of those states that was silent on the impact. And it was one of these things that they didn't know what to do. So legally, they decided that it would be best to keep her alive and gestating, basically, until there was a legal determination. But think of what that family had to go through. You know, they'd already made the decision to remove her from life support, but then they had to sue the hospital to do that. God knows how much money they spent. So, it's one of those things. So, it's one of those states, you know, it's one of those things that you get very, very sticky whenever the person's pregnant. All right, questions about this? All right, let's do cerebral infections and hydrocephalus. Because this sort of flows. I think that a lot of the material from this lecture actually came from London, came from your child's book. Basically, one of the things that you'll see, just to give you an idea, this is what a brain looks like that's pus covered with meningitis. This is what hydrocephalus looks like with very, very enlarged ventricle. Normally, what you will see is these nice little slits. Yeah, it looks like a skinny butterfly. But with hydrocephalus, you see this great, big, big, big problem there. All right, meningitis. Like it says, it is an itis or an inflammation of the meninges. Remember, there are 3 meninges, and they're what? All right, dura, arachnoid, and pia. Okay? They form a pad. Pia, arachnoid, dura, to protect the brain. That's the way you remember. Pia is very thin, and it sits on the brain itself. Arachnoid is the middle layer, and typically there is CSF under that arachnoid space that sort of the brain floats in. The dura sort of adheres to the skull, and there's really not a space between the dura and the arachnoid usually. Okay? But those 3 layers sometimes get inflamed. Viral meningitis is usually very self-limiting with complete recovery. You will see it from measles, mumps, herpes simplex, and herpes zoster. All right, so a lot of viral illnesses. The other one that you often see is chickenpox. Can cause it. That's varicella. But often what you find is that sometimes people with varicella meningitis are left with some difficulties. That's why the chickenpox vaccine was invented. Because a woman that had a child that developed meningitis encephalitis from varicella, her child died. And she petitioned and got the drug companies to come up with a varicella vaccine. It used to be that, I don't know, back in my day, somebody in the neighborhood had chickenpox and every mother and their brother would bring their child over to play with them so that they would get the natural immunity. So half the neighborhood would have chickenpox at one time and then you didn't have to worry about it. But sometimes it does cause meningitis encephalitis, and people can die from it. Now, bacterial meningitis is potentially life-threatening. Okay? Some of the predisposing conditions that you see: otitis media, or ear infections, pneumonia, acute or chronic sinusitis. You can see it from brain surgery or an open head injury. Okay, open means that the scalp and the skull have been breached. What happens is that pus does form and it spreads to the cranial nerves and spinal nerves. You can also have fungal infections or protozoans. But bacterial and viral are the most common causes. Now, the big bad is meningococcal meningitis. It is a medical emergency with a very high mortality rate, often within 24 hours. It's highly contagious, and it occurs most often in fall and winter when upper respiratory infections occur. Yes.
So whenever I went to the doctor's office to get my shots, like before this, my doctor told me his brother actually died from, I don't know if that, but I didn't know that was like a common thing to.
It is for my generation.
Okay.
For your generation, you've been vaccinated. Okay? My daughter, when you work at Duke, you get the benefit or the sometimes I don't know, let's say you just get the benefit of being in studies. Okay? She was in the first study for meningococcal meningitis vaccine, because that vaccine, the Menara vaccine. So it was one of those things that she had her doses of vaccine as an infant, so that whenever 7th grade came and they started vaccinating everyone, she was so pleased because she didn't have to get it, because she was also in the first ibuprofen study for kids. So it's one of those benefits. So, but anyway, typically you don't see it as much anymore because people have been vaccinated against it. Okay? It's one of those things that you see a lot in overcrowded situations, like army barracks or dorms or overcrowded schools where there's a lot of contact. But we're seeing a decreased incidence of it because of the vaccine. Okay? But you're right, a lot of people did die from it. and I'll show you why in just a minute. With viral meningitis, these are what you see: fever, photophobia. No, that's not a fear of getting your picture taken. It's fear of light, okay? Meaning that light hurts your eyes. Upper respiratory tract infections, symptoms, headache, myalgias. What is a myalgia? Muscle pain, nausea, vomiting. Herpes simplex 2, because genital lesions, typically what you see is treatment is symptomatic. You know, if it's due to herpes simplex, a little acyclovir will decrease that swelling. Fungal meningitis, typically you see symptoms very due to the compromised immune system. You see fungal meningitis in people that have had chemo or radiation or are HIV positive with AIDS. Okay? Someone that has a very compromised immune system. Headache, nausea, vomiting, decline in neurostatus. Again, treatment is symptomatic. Depending on what fungal infection, one of the drugs of choice is going to be amphotericin B, also known as amphoterrible, because it has all sorts of side effects that makes it very unpleasant to get. Now, meningococcal. What you see is a very sick person. They have a rapidly decreased level of conscious, nausea, vomiting, severe headache, nuchal rigidity, which means what? Neck stiffness. Okay? This is the one where they have you to do chin to chest and then have you move back, and if it hurts, that's positive for neck stiffness. Typically with meningococcal, you will see a rash, you will see a patient that has tachycardia, and you will see someone that may have seizures. It's a medical emergency, and it has a very, very high mortality rate. Like I said, the vaccines, Menactra or Minimmune, they're typically given to children aged 11 to 18, or in high-risk adults 19 to 65. But most of you got this in 6th or 7th grade. Okay? The usual adverse effects are just pain at the injection site and headache. But it will prevent meningococcal meningitis. Basically, one of the things that you can tell is it's a rash. You take a glass and put it up against the rash. If the rash doesn't disappear, that's an ominous sign. It's a symptom of bacterial meningitis. Okay? Basically, what happens here is because of this meningitis, they develop septic emboli. They're throwing little bacterial colonies, and what you get is infarction of the fingers, the toes, the feet. The bacteria clog the arteries. So you see septic emboli. And what happens is that if this person survives, they will lose those fingers. Because basically you can see that's dead tissue. A lot of patients that do survive with limb loss. Yes?
Whenever I was in college, my first time, my boyfriend had his roommate had that. He survived, but he lost part of his fingers.
Yeah, I've seen people lose all four things. Now, one of the things that you will see with bacterial meningitis is that what they call an apostonic position, okay, which means they sort of curl backwards. Because what that does is that it decreases tension on that spine and the cranial nerves. And it hurts less in that position. Okay? So that if you were to look at this child, you can see how bowed their head is. They almost are like a backward C. Koenig sign, remember that one? No? Koenig and Brzezinski's are what we use to test for nuchal rigidity and resistance. Basically what you do is you flex the knee and then extend it. Okay, if it causes pain in the neck, that's positive. Okay, commonly found in meningitis. Brzezinski's, that's with the head in the supine position. Basically, if you elevate the head, the knees will come up. So what you see is to decrease the pain of the stretch. And again, a positive Brzezinski's is common in meningitis. Correct. All right, so how are we going to test for this? Lumbar puncture to do a CSF analysis. CSF analysis, we're going to send it for not only gram stain, culture and sensitivity, but we're going to look at what the components are. Typically with bacterial meningitis, what you will see is a high protein and low glucose. If it helps you to remember it this way, do it. The bacteria eat the glucose. The protein is the bacterial cell walls. Okay? High protein, low glucose. Now that's bacterial. Viral, it's usually normal. We will do blood cultures because not only do a lot of these patients have a neurological infection, but they can become septic very easily. And sepsis is also a bad thing. We want to rule out any other causes for that infection. X-rays, CT, MRI. Basically, MRI will show you the pus in the meninges and brain swelling. Again, elevated ICP is going to be a problem with these folks. That's why they get the symptoms. Most important nursing interventions are monitoring and documenting their neurologic status and remembering that acute change in their neurologic status is your most sensitive indicator of what's going on inside. Neisseria meningitis is also a type that you will see, but it's also highly contagious. Often what you will find is that if someone comes into the emergency department with suspected meningitis, people will gown and glove and mask for droplet precautions because you never know. Is it meningococcal or is it Neisseria? Neisseria meningitis has to be isolated with droplet precautions. It's also very highly contagious. Typically what you will see if people are exposed to this, they will give them prophylactic antibiotics with either rifampin, ciprofloxacin, or ceftriaxone. H. influenza Okay, just like regular flu, you can get meningitis from that as well. Again, droplet precautions and prophylaxis with examine if you have meningitis. Okay. Questions about meningitis. Most of the time what you're going to do is supportive care, manage their pain of their headache, manage their nausea, and give them either antibiotics, depending on what kind of meningitis it is, or if it's viral, you may be giving them antivirals, or if it's fungal, you give them antifungals. The majority of these patients do quite well, unless they're the people, the meningococcal, that have not been recognized for what it is very quickly. And they die sometimes within that 24 hours. All right, hydrocephalus. What does it mean?
Water on the brain.
Water on the brain. Okay. So if I call you pneumocephalic, what does that mean? But you're an airhead. Pneumo, think of lungs. Pneumocephalic means air in the brain. Okay? Hydrocephalus means water in the brain. But it's not really water, it's just extra CSF. With hydrocephalus, you see two different types. There's communicating hydrocephalus and non-communicating. And we're not talking about talking. Oh, really? No. Communicating means flow, okay, in this situation. Communicating hydrocephalus means that there's no blockage to the flow, that it flows like it's supposed to, but there's just too much of it. Non-communicating hydrocephalus is there some kind of blockage, either brain tumor or a lot of times what we see is after traumatic brain injury or stroke, there's blood in the villi that reabsorb the CSF. So what you get is a blockage to the reabsorption. Clinical manifestations are going to be pretty much age-based, though you will see headache and neurological decline. Okay? If their cranial sutures are closed, headache, loss of neurofunction. And in your elderly patients, incontinence, where they have previously been continent. How do you think that would be a sign? Where is the voluntary control of nutrition or eating? Looking. Actually, it's from the lungs. Okay. So what you see when you get pressure on there is they're not able to voluntarily control when they go. They've had 13 babies, they're not going to be able to control it anyway. But they at least know they've got to go. Now, with kiddos that sutures have not closed, but they still have that anterior fontanelle that's not completely closed, you will see bulging there. Okay, bulging fontanelles, a sign of hydrocephalus. If the sutures have not closed, or have closed, not closed, crap, I can't even get it straight. All right, you got a kid that's 9 months old, and their cranial sutures are not matured and they have not closed, you're going to see an increase in head circumference. So that's why they check on those. Normal pressure hydrocephalus is often what you see with your elderly patients. All right, there is a problem with their brain and they've got too much CSF, but because they've lost brain atrophy, I hate to tell you guys, your brain starts atrophying at age 40. So mine's almost gone. But what happens is that because they've got brain atrophy, they're able to accommodate for that extra CSF. So their ICP stays normal. Okay, remember Monroe-Keeley. If one thing increases, the other decreases. Well, in this population, they've got brain atrophy. They've got more CSF, but they're able to accommodate for it with normal ICP because there's room. Typically, you see gait disturbance. You may see what they call a magnetic gait. In other words, whenever they're walking or they get up, you might see them do this. It's like their feet are stuck to the floor, okay, before they start walking. You may see dementia. One of the first things that they will check patients for if they're starting on that workup for dementia will be normal pressure hydrocephalus. They slow in their thinking. They slow in their spontaneity. Urinary incontinence. Personality change and Parkinsonism. These people rarely have headaches or seizures because they're able to accommodate that extra CSF in their brain because of that brain atrophy. Elderly patients. Okay? Now, with kiddos or anyone that needs a shunt, the definitive treatment for hydrocephalus or extra fluid is you shunt it off. Well, what happens is that they will place a shunt and it'll go into the lateral ventricle, and then here there's a little tube that's a valve, and that's on the skull, and then they tunnel this tube down the neck and put it in the belly. So that what happens is that when the pressure in this lateral ventricle gets high enough, this valve will open and it drains CSF. Now, I've just done this in a 6-month-old. What are going to be some of my problems as this kid grows?
I need a bigger shunt.
The tube needs to be longer.
The tube needs to be made longer, and a lot of times what you will see is they will do a shunt revision and replace that tubing. What else could happen? They won't pull on it because it's underneath their skin.
Displacement?
It can get displaced, okay? But what would you worry about here in this belly? You know, it could entangle the intestines, or it could cause adhesions, okay? Anytime you mess with the gut, it's going to make scar tissue. But if you get scar tissue here, what could it do?
Alias.
Obstruct the shunt, okay? What else is nice in this gut? What we have in our guts?
Flora.
We have acid, we have normal flora. Sometimes those flora leak out. So they can travel right up that shunt and go right into the brain. E. coli, probably one of the big infections that you see. So there are all sorts of things. Now, if this shunt becomes occluded in some way, what signs and symptoms am I going to see in my patient? Headache.
Level of conscious change.
Level of consciousness change. Vomiting. All of the signs that you see with increased intracranial pressure. Okay? What am I going to see if I've got a shunt infection? Fever. And you may also see some of those ICP changes because it can get pussy and quit draining. Okay? Now, what type of care am I going to have to teach these parents after this child has this shunt? Right? Okay? And what should I tell them to do if they see those symptoms? Take them to their healthcare provider as soon as possible. Okay? Again, if this is a 6-month-old, I'm going to continue to measure that head circumference to make sure that they're not continuing to increase, because once the shunt is placed, they should be within that normal growth chart for that head circumference. Now, initially what you will see is that when these patients come back from surgery, they're kept in a flat position for 24 hours. Okay? Doesn't matter if it's a kid, doesn't matter if it's an adult, doesn't matter what their age. Why would you think that they keep these folks flat? So that it doesn't gain too quickly, because what usually will come in instead, you're going to have blood coming back in. And if you drain these people too quickly, they can suffer bleeding. Okay? So you don't want to drain them too quickly. All right, just as an FYI, one of the reasons that we all suffer from hangovers is because you dehydrate yourself and you don't produce enough CSF and your brain sinks in your skull. And that's why you get the headache. So hydrate so that you can replace your CSF. And therefore you will not have that headache. And don't take Tylenol with that headache, because you don't want to take alcohol and Tylenol at the same time. Okay, because your liver ain't going to tolerate it. But drink water before you go to bed. Yes.
Have you heard of those clinics around Charlotte where if you have a hangover, you can hook you up to like an IV for like 45 minutes?
Yeah. It's like an O2 clinic.
Oxygen and an IV. I mean, you can, and it costs about $100. Drink water and breathe deep.
Yeah.
But that's true. If you are able to hydrate, it's just because your brain sinks, because it's not able to produce enough CSF. Typically what you will see is that people produce anywhere from 300 to 600 milliliters of CSF a day, but only about 100 to 125 cc's is circulating at any one time. So it's constantly being produced and reabsorbed, and constantly reabsorbed. The thing is that you have to have a normal volume of blood for that CSF to be produced, because it's a filtrated blood. If you're dehydrated, it's less likely to produce enough CSF. So yeah, IV fluid would work just fine, but so would drinking 3 glasses of water. It's a whole lot cheaper than $100. But I guess misery loves company because they have them lined up at the bed.
Can we take another break?
Let me finish this last one. And then we will. Knowledge of signs and symptoms, shunt malfunction, periodic reevaluation. This is not one and done. A lot of times whenever these are placed, you typically will see 6 to 7 revisions over the lifetime of the person. So pumping the shunt. Now I'm going to tell you, Grandma, great-grandma, or Grandma will probably say, now you need to take and pump this shunt. You don't anymore. Because what they used to have to do that about 40 years ago. But now there's a pressure valve in there that can be damaged if you pump that shunt. So basically what you overcome is that pressure gradient, and then it opens and drains. It doesn't drain all the time. Basically, vascular shunts, some patients with other type of shunts, they think about prophylactic antibiotics for dental procedures or any invasive thing. A lot of times what you will see they may do, instead of the VP, ventricular peritoneal shunt, they may do a VA shunt, meaning that it goes right into their atrium. They don't do that as often anymore, but if they do a VA shunt, you definitely need prophylaxis before any type of invasive procedure. But shunts, the book is very self-explanatory about what they do and what they care about. So let's go ahead and take another break. Be back about 15 after, and we'll start.